My name is Mark Furse. I'm Secretary General of the European Association for Study of the Liver, and I'd like to welcome you to the 2013 International Liver Congress. I hope you enjoy what's going on, but I know that you've all got a job to do, and we'd very much like to help you to do that job as best you can. We have selected, as you will appreciate, some studies that we think should be interesting to you. By no means is this exclusive, so you know, there's plenty of other stuff going on over the next few days that you may well be interested in. We have selected abstracts based on a number of criteria, one of which, of course, is that we think these will have an impact on patient care in the not too distant future. Okay, now we're doing something slightly different this year. We're doing, instead of one big press conference that covers absolutely everything, we're going to do 3 press conferences today. You'll not be surprised, we're going to talk about viral hepatitis, well actually just hepatitis C, because obviously that's where the exciting new drug data is coming through. But we will have sessions over the next 2 days covering hepatitis B and also hepatocellular carcinoma and non-alcoholic fatty liver disease, and also some data on the management of cirrhosis. There's some good stuff coming through. I think some highlights I think that you can expect in the next couple of days. New drug trial on hepatitis B patients who are so-called immunotolerant. If you look out for that, immunotolerant patients with hepatitis B have incredibly high viral loads but apparently no liver disease. I think our view on that is changing, that potentially these patients have a risk of developing cancer in the future. In addition, that because of their high viral loads, these patients are at risk of transmitting the infection, so there's some new drug trial data that you should look at. Also in hepatitis B, some data that you could look out for, potentially exploring the chances of curing hepatitis B. So I'm going to show you some data in a minute on C. When we talk about sustained virological responses, you'll see we're talking about a cure of the infection. In B, we normally suppress rather than cure, a little bit like HIV. In fatty liver disease, I think the link between alcohol and fatty liver is going to be explored mainly from an epidemiological perspective. Look out for that. There's also some interesting data to suggest that if you exercise, you've got a chance of reducing your risk of liver cancer. I think is a good message to get out there. Some data coming through later this week. Some abstracts, not particularly that we're going to present, but that you'll see in your press packs, cover some of the more exciting, purely scientific advances. And if you want to know more about those, you want to do interviews, please feel free. As 1 or 2 people have already pointed out to me, if I just present the data in the next few minutes and I don't give you some clinical implications, then perhaps you could prompt me when it comes to the Q&A session. And the same goes for my colleague Laurent Casterat from the EASL Governing Board, who is co-presenting this session. So, I'm going to cover some of the new DAAs, which I think are pretty much ready for prime time, a few that are coming along quite quickly. And then after I finish, Laurent is going to cover the existing direct antivirals and therapies for hepatitis C. And you can see what's happening in that field, which of course has implications for our patients right now. One thing I'd like to point out, we have this burden of liver disease study. If you haven't seen it already, it's available on the EASL booth. So this is a systematic review of the morbidity and mortality, the incidence and prevalence of all the liver diseases across Europe based on the published literature. Inevitably, therefore, it's probably an underestimate, and yet I think you'll see that, well, sadly, in many respects, that liver disease exerts quite a burden in terms of disease, morbidity, mortality on our population. Alcohol remains, of course, the number one cause of liver disease, but viral hepatitis comes in at a close second. And the good news about viral hepatitis is there's something we can do about it. When we go into talking about some of the trials, I wanted to point out to you that the distribution of viral genotypes in hepatitis C in Europe is slightly different than you will see in the United States or Japan and some other regions of the world. We're pretty mixed, actually, in Europe, and genotype 3 is quite common here. So you can see genotype 3 shown in the green segments of these pie charts here. So we have plenty of genotype 3, and the data on genotype 3 is therefore very relevant to our populations. So what about the new direct acting antivirals? So of course what we're really interested in here is the key phase 3 data, and the drug perhaps that's moving forward so rapidly at the moment is sofosbuvir, which is a difficult word sometimes to come out. I loved it when it just had a number, it was so much easier. Okay. So 3 trials from Gilead addressing genotypes 2 and 3, fission, positron and fusion. Fission is for treatment-naive patients, fusion for treatment-experienced patients with genotypes 2 and 3. I also wish, as an off-the-cuff comment if you like, they wouldn't lump genotypes 2 and 3 together, and I'll justify that as I show you the data. And then there's another group of patients who are so-called interferon intolerant, ineligible or unwilling. Now, all of us given a choice would choose an interferon-free regime versus an interferon-containing regime, no doubt, but most European investigators would not recognize so much this group of patients, but clearly they're there. And then we'll talk about the neutrinos study, which dealt with what used to be considered the harder to treat genotypes. That's 1, 4, 5 and 6, not that we see so many 5s and 6 around. And these are treatment naive patients. So the fission study, as I said, these are genotype 3. This compared sofosbuvir and ribavirin for 12 weeks compared to what is currently standard of care, 24 weeks of pegylated interferon and ribavirin, genotype 2 or 3. This is the trial design, nearly 500 patients, 72% of them genotype 3, 20% cirrhosis. I think those are important parameters in the patient populations. These are the results in terms of SVR12, which, as you know, has now become pretty much the standard accepted by FDA and I believe EMEA. So absence of detectable viremia 12 weeks after the end of therapy. So in genotype 2, you can see the data there, 97% in the sofosbuvir arm of the study achieve SVR. This seems to be a done deal. It's an easy to treat genotype. Genotype 3, I don't think this matched our expectations. I think 56% in this group is, it makes you question whether you would go down this route, I think. The cirrhotics you would expect, of course, to have lower SVR rates, as illustrated here. So moving on to the fusion study, this is treatment-experienced individuals. This is looking at 12 weeks or 16 weeks of therapy, and this is quite an interesting, this duration of therapy I think is going to turn out to be one of the most interesting phenomena around the treatment of this group of patients. And again, you see quite respectable results in genotype 2, not perhaps as exciting the results in genotype 3 here. In the 12-week arm, you can see 30% response, and then you're getting up in 16 weeks to over 60% sustained virological response. And of course, to me, it begs the question, well, what if you treated them for a little bit longer? What about these ineligible, intolerant, unwilling patients? There's some with cirrhosis, some who just can't tolerate having pegylated interferon. So this, interesting, because of their intolerance or unwillingness or whatever you want to call it, there is a placebo arm, a novelty now in hepatitis C trials, but you are going to see a few more of these coming along. And that you can see there were 207 patients treated with sofosbuvir and ribavirin, and I guess you can take this data together with the results that I showed you previously. So 20% of the patients had cirrhosis, and actually quite good. There was no limit, in fact, to age or BMI. Most of you will know that patients with high BMI tend to have poorer responses, particularly a BMI over 30 kilograms per meter square. So these are the reasons why patients were either ineligible or intolerant. They are the usual things that you would expect amongst a group of patients, and perhaps in some centres, if they had a high clinical need, we would have pushed these patients through if we hadn't got an option. But nevertheless, these are the reasons why they were not considered eligible for interferon. These are your 12-week post-treatment responses, 78% overall. That's genotypes 2 and 3. So surprisingly enough, it met the endpoint criteria, i.e. it was better than placebo. This is not a surprise. Okay, but let's break that down. Again, you see genotype 2, 93% SVR, genotype 3, 61%, and 61% in cirrhotics. So again, okay, this is good, but perhaps a little less than we might have hoped for, I think. This is not my conclusions, this is company Gilead's conclusions. One thing I do want to draw your attention to is that there was no resistance. So they've obviously done a lot of virology on this. There's no resistance. The importance of that means you can continue treating those patients for longer periods of time. Basically, what I was saying earlier was I think perhaps we are keen to see what happens when these patients are treated for 24 weeks or beyond. Neutrino study, this is using sofosbuvir in combination with pegylated interferon and ribavirin in genotypes 1, 4, 5 and 6. So remember, we would in the past have treated these patients for 48 weeks with peg and riba. Often with a protease inhibitor you can treat them for shorter durations, but nothing like as short as 12 weeks before. So for the patient's point of view, 12 weeks of therapy, that's a major breakthrough. This is a design, it's a single arm study, open label, and 20% of the patients had cirrhosis. Again, inclusion criteria, no upper age limit on age or BMI. And actually some quite respectable parameters around platelets, neutrophils, etc., which means that it covers the majority of patients that we would see in the clinic, which, as you know, sometimes isn't the case in clinical trials. These are the headline SVR on the right-hand side of this, 90% achieved SVR 12. Which again was better than historical control rates and better than placebos. Breakdowns look like this. Genotype 1, 89%, it's phenomenal. Yeah, it's a good figure. Genotypes 4, 5 and 6, of which the majority are in fact genotype 4, 97%. You can see there that cirrhotics did well. Previously, we knew that people of African origin didn't do so well on treatment. Here, they're doing almost as well as non-Africans. High viral loads still do well. And there is some impact of the IL-28 genotype, as you can see at the bottom there, but it's not devastating. There can't have been that many people in this study who relapsed because of the success rate, but in those that did, you can see again no resistance developing. And okay, we haven't highlighted this. There is another study looking at quality of life on patients on these regimes. Quality of life in patients being treated with sofosbuvir didn't seem to increase adverse events, seemed to be extremely well tolerated in all of these studies. So moving on, what about the second generation protease inhibitors? They're also some of these now in phase 3 studies. So we were talking mainly about boceprevir and telaprevir for the last couple of years. Now we have faldaprevir and cimipravir. Faldaprevir from Boehringer Ingelheim in combination with pegylated interferon ribavirin, usual sort of thing in a multi-center study. This is the design of the start verso study. So you've got here a placebo plus peg and riba arm, standard of care as was, and 2 doses of faldaprevir, and there are some response-guided criteria that were used in the trial, albeit actually quite a lot of them met the criteria and therefore had shortened periods of treatment. These are your headline SVR rates, SVR12. Again, you can see not much difference between the 2 doses actually. 80%, which is indeed very good. They defined a criteria called early treatment success. This was based on a viral load of less than 25 international units at week 4 and at the end of week 4 and undetectable at week 8. So slightly different than extended RVR. And you can see those who met that criteria did extremely well. What's important, I think, here, and what we have to contrast a little bit with what Laurent will show you in a few moments, is that the safety profile and the adverse event frequency is low on this drug. Okay, so this is going to be far better tolerated by our patients in the clinic than the existing protease inhibitors. Skip through that one. There are 2 phase 3 studies of cimipravir, what was called TMC 435, Quest 1 and Quest 2. I'm presenting to you the data from Quest 2 here purely because this one was run in Europe and then Quest 1 was run in the United States, and I have to exert some biases, I think. So, but the results, as you'll see, either if you go to the presentations or look at the abstracts, you'll see that they are very, very similar. These are trial designs, always useful, response-guided therapy, cimipravir, once daily, 150 milligrams for the first 12 weeks, and then going on up to 24 or 48 weeks, depending on the response, at 4 weeks. Primary endpoint, of course, is SVR, and these are the patient characteristics, a normal sort of distribution for this sort of trial, as you can see, and these are the headline figures. The portion of people achieving SVR, again, 80% plus, and again, I'll get to the adverse events in a minute. You can see that over 90% of them actually met the criteria for response-guided therapy and therefore only required 24 weeks of treatment. That's important. And you can see from this list here that the side effect profile was no worse than pegylated interferon and ribavirin alone. So we've got used to the fact now that if you triple therapy regimes that are currently in practice, you have a worse or exacerbated side effect profile. These new protease inhibitors, it seems to be better. More patients get shorter periods of treatment, and indeed more patients get cured. There is, of course, so that was phase 3 data. I'll briefly highlight some promising phase 2 data. Electron study, so another Gilead study, of course, this time combining sofosbuvir with ledipasvir, was 5885. This Gilead combination. So previously they have done in genotype 1, as you've seen, sofosbuvir and ribavirin. This was phase 2 data, and they said, well, what if we add in other direct-acting antivirals plus ribavirin in naive or null responder patients? So, so this is what they're showing us here. So 5885 or ledipasvir, that's an NS5A inhibitor, and 9669, which I believe doesn't yet have an unpronounceable name, is a protease inhibitor, and this is their results. Just look at the bottom line here. Really, it's the SVR12 data that we're interested in. I can focus in on that. You can see some encouraging results there. But we've seen encouraging results with these small numbers before, and yes, I'm excited to see what happens in phase 2, but we're in phase 3, but we're not there yet. Let's see. Adverse event profiles, as you can see from this graph here, look excellent. Again, a word of caution about what that means in due course. That's right, I skipped through that. This is company conclusions. Again, I think these are reasonable. They're getting high levels of virological responses, good levels of tolerability, obviously not much in the terms of resistance if all of the patients have cleared the virus. Moving on, another interferon and ribavirin-free regime from BMS, this time rather than Gilead. This is declasisvir with asunaprovir, and treatment-naive genotype 1 patients. As you can see, this is a slightly complicated slide looking at their phase 2 study design. So asunaprovir, by the way, is a protease inhibitor, declasisvir NS5A inhibitor, and this time last year, you remember we talked about declasisvir and sofosbuvir, which looked extremely good, but for commercial reasons they've gone in different directions, although there is a study, I think Laurent's going to show you later, which is still ongoing. What's the data look like? Well, of course, it looks extremely encouraging, but small numbers, phase 2 study, good side effect profile. Declasisvir not so good against genotypes 1A as genotype 1B. So it's one of the issues that we're now facing in that not all genotype 1s are the same, and we have to recognise that. And then Abbott, this is an all-oral regimen of, in fact, 5 drugs combination from Abbott, the Aviator study. Again, sorry, a complex trial design for you, incorporating both treatment-naive individuals as well as previous null responders to pegylated interferon and ribavirin, so a difficult-to-treat patient group. And you can see SVRs on the right of that graph, extremely impressive. And that this is now already in phase 3, this combination. This is the SVR24s by subgroups. So you can see, it seems that actually this combination is good against 1A and 1B, high viral load, low viral load. Don't think there are cirrhotics in this group, which is why you've got F2 to F3, and the IL-28 genotype makes not too much difference in this group of individuals. That was the naive patients, this is the previous null responders, and I guess this is really one of the more exciting bits of data. So an all-oral regimen with reasonable numbers of patients at phase 2 and some really high sustained virological responses. So I'm obviously quite excited to see that come through in phase 3 data. So my conclusions, well, we've got some really potent regimens ready for the clinic. You know, we'll see those, I think, early part of next year. We'll be moving into the use of protease inhibitors, which are much cleaner profiles available than the current ones that we're using. And perhaps just a little word of warning, it's not quite time to bury the interferon yet.